राकेश, हेलो। हाँ ठीक है, अभी मैं आपको होस्ट बना देता हूँ।
Who's presenting today?
Sir, please guide me to whom should I make co-host. Please, sir.
Good evening, all.
Good evening, Gite sir.
We will wait for 5 minutes and we'll
Yes,
start.
sir. Yes.
Okay.
Good evening, Hiren sir.
Who is presenting today?
Good evening. Good evening.
Sir, I am presenting, sir, Dr. Abhishek from Jaslok Hospital.
And another one?
Second person, I
Dr.
don't know.
Yasir, sir.
Ashir?
Yes, sir.
Okay. So make both of them co-host. Yeah. Ashir is from which hospital?
KDS, sir. Popular Dana. Guru Hospital.
Okay. Vivek. Vivek. Vivek is joined? Vivek Shah?
Hello, sir. Am I audible?
Yeah. Please share your screen and start.
Yes, sir. Yes, sir. Just a second. Just a second. Sir, is my screen visible? Hello? Hello?
Good evening, sir.
Hello?
एक पीपीटी भेजा है लेकिन वो प्रेजेंट करने
हाँ।
वाला है वो मेरे को बताया नहीं सर।
हाँ
वो पीपीटी है मेरे पास, मैं प्रेजेंट कर सकता हूँ अभी, लेकिन मैंने केस देखा नहीं वो वाला सर।
किस कौन सा?
हाँ ओके 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 ओके।
हेलो अंकित।
हेलो सर?
हेलो।
हाँ बोलो।
सर मैं प्रेजेंट कर रहा हूँ सर अभी।
हाँ मैम वो,
ठीक है करो।
हाँ मैम वो वाला प्रेजेंट करना है, मैं प्रेजेंट कर रहा हूँ अभी।
सर अभी आ रहा है?
हाँ
सर स्टार्टिंग द केस
हाँ,
सर।
वो
गौरंग
एक्चुअली
सर ज्वाइन हो गए? सर
सर स्टार्ट करें? हेलो?
आपका म्यूट है। हाँ विवेक को बोला है शुरू करने के लिए।
कौन कौन प्रेजेंट करता है?
विवेक।
ओके तो
यस सर, आई एम प्रेजेंटिंग सर।
आपका आवाज ब्रेक हो रहा है सर, सुनने में नहीं आ रहा कुछ भी।
ओके विवेक ने ओके
sir.
ओके देन
Sir, I'm starting the case, sir.
ओके
Sir, the patient is a 60 years old Hindu gentleman who is a shopkeeper by profession, resident of Mumbai, presented with a chief complaint of difficulty in micturition for the last 2 years.
हेलो
हाँ सर।
Sir,
हाँ ओके अभिषेक, दिस इज द ओनली कंप्लेंट, हाउ विल यू गो अहेड?
Yes, sir. Sir, given this complaint, sir, I would like to first characterize the complaint. What type of difficulty in micturition is he having? Does he have voiding symptoms or does he have storage symptoms? What is the onset, duration, and progress of those symptoms? And what is the
Hello?
bother? Hello.
हेलो यू कैन
सर सर आपका आवाज ब्रेक हो रहा है,
हेलो
आपका आवाज ब्रेक हो रहा है सर।
गीता सर
हाँ
कैन यू हियर मी?
यस सर।
डॉक्टर गीते कैन यू हियर मी?
यस सर, यस यस आई एम हियर, आई कैन हियर यू सर। हेलो
हेलो
हाँ सर,
हाय
आपका नेटवर्क का इशू है शायद कुछ।
डॉक्टर गीते कैन यू हियर मी?
यस सर आई कैन हियर यू सर। आपको आवाज आ रही है मेरी?
hello.
Sir must be busy in OT. Dr. Vivek, you can continue.
Yes, sir. So the chief complaint is difficulty in micturition for the last 2 years. Should I move ahead, sir?
Okay.
As per the history of present illness, the patient complained of voiding LUTs, specifically for the last 2 years, which was progressive, getting worse. The frequency was during daytime every 1 to 2 hours. There was also nocturia associated with it. Nighttime frequency was 2 to 3 times. Staining positive. Narrowing of urinary stream was there, and feeling of incomplete voiding was there.
So Abhishek, what is mean by frequency?
Sir, frequency can be daytime frequency and nighttime frequency, sir. Frequency means, sir, increased, sir, decreased time duration between two voiding episodes. during the day. So normally it is 3 to 4.
Definition of frequency as
Yeah,
per
first-
the International Incontinence Society is
Correct.
passing the
Correct.
urine more than how many times is called as frequency.
More than 8 times. This is the first sentence that should have come.
Yeah.
Both
So
of
no-
us have
no-
noticed the same thing. And
Yes.
the person who is presenting the history said voiding blood. Why do you have to use such terminology? Patient has come and said voiding blood. After saying voiding LUTs, then you are saying frequency. First symptom.
Yes, sir. So it should
You
be
should have
LUTs.
said patient is having difficulty in passing urine or complains of low urinary tract symptoms, and these are the symptoms.
Yes, sir.
If you are going to use terminology like patient has said voiding LUTs and then you start saying frequency hai, nocturia hai, and Abhishek while defining you are saying that they can be daytime also and nighttime also. That is not correct. More than 8 times in the day is called frequency.
Yes. Then how many times in the night is called as nocturia?
Sir, 2 or more than 2 times during the night, which is preceded and
International
succeeded by.
Incontinence Society, as per the International Incontinence Society, passing urine once also is called as next. Current definition.
Okay, sir.
Initially, it is more than one.
Agreed.
Okay, sir.
So symptomatology, initially it is a prostatitis or prostatism. Later on, it is called as irritative LUTs. Now it is called as storage LUTs. So lastly, it is voiding and storage. So what are the storage symptoms? Can list the storage symptoms.
Frequency, urgency, nocturia, avoiding symptoms, precipitancy, intermittency,
Baba, storage symptoms.
poor stream.
Abhishek,
Yes, sir.
Abhishek, you are getting confused. Sir said storage symptoms. Tum correct start kiye.
can list the storage symptoms. Simple question.
Frequency, urgency, nocturia.
Frequency,
Simple.
urgency, nocturia. Yes, sir.
What are the voiding symptoms?
Poor stream, intermittency, sense of incomplete micturition.
देखो इसमें there should not be any confusion in telling the 7 symptoms on which the IPSS score is based.
Yes.
So how many storage, how many voiding, ये इसमें कोई confusion नहीं रहना चाहिए.
Simple, peace, fun, poor flow,
Yes, sir, yes.
intermittency, straining, sense of incomplete evacuation. It should
Yes,
come
sir.
even in your sleep. If your wife wakes up and asks you, you should tell.
So
Yes.
on the basis of these symptoms, IPS International Prostate Symptom Score Index, how it is divided, how it is made.
mild, moderate, and severe.
Yasir, go ahead, Yasir.
Yes, sir. Mild, moderate, and severe. Mild is 0 to 7, and moderate is 9 to 19, 8 to 19. Sorry.
8 to 19.
And yes, sir, 8 to 19. And 20 to 35 is the severe. This is how we grade it.
Out of all these symptoms, 7
And what-
symptoms, which you think is the one symptom which tells you that patient has prostatic enlargement? That one symptom. ये गणेश गोपाल कृष्णन का question है.
Nocturia, sir, is the
Patient goes and he says that I am standing and just not able to initiate. Hesitancy.
Yes, sir.
That is a very clear symptom of
Hesitancy.
prostate. He goes there and he feels that bladder is full and he thinks that he will press strain and he will not be able to start urination.
Then what are the other ways of assessing the severity of symptoms except IPSS? Abhishek
we
will
have
will
AUA,
tell one and
symptom
Yasir will
score
tell
also.
one.
We have sir,
Follow.
AUA symptom score.
Okay,
AUA symptom score.
agreed. What is AUA symptom score?
In AUA symptom, this is American Urological Association symptom score. We have an added quality of life score. We grade from 0 to 5. This is about the satisfaction of the patient. If the patient has to live with these complaints for whole his life, or how he will grade it, whether he is happy or he's not happy.
Abhishek.
And one more score, sir, we can have CLSS score, that's core lower urinary tract symptom score.
What is the
And
bothersome index?
plus, sir, that's bothersome index is about the quality of the QL symptom score only, sir.
So bothersome index is important or IPSS score is important?
Sir, bothersome index is important. So degree of bother should be known,
Yes.
sir. Depending on that, we can plan our management, sir.
Okay. Vivek, go ahead. Vivek.
Yes, sir.
These
IP
things should go super fast. Otherwise, you are not going to reach management.
Yes, sir.
हाँ, क्योंकि इतना slowly नहीं कर सकता, आप
Yes,
फटाफट बोलो.
yes. The IPSS score for this patient was 18 of 35, with frequency been 3, nocturia 3, post void 4, poor stream was 4, straining was 4. So it was a moderate stream. What are the negative histories? There is no history of urgency.
Wait. Don't show the history of negative history slide. Okay. So after chip complaint and elaboration of chip complaint, what negative history you want to ask? So for asking the negative history, there should be some 2 to 3 diagnosis in your mind. So tell me, Yashir, what negative history
Sir, any history of incontinence,
you want to ask?
any history
फटाफट
of dysuria, any history of fever, any history of such events before, any history of any retention of urine, any history of catheterization, any history of surgery, any history of trauma, any history of hematuria.
So what are the probable diagnoses you are expecting in this patient? As per that diagnosis, you have to ask the negative. So if you
Yes,
are
sir.
expecting
This
BPH,
is
if
the
you are expecting
bladder
CA
outlet
prostate, if
obstruction.
you are expecting bladder stone, if you are expecting BUJ stone, then 2, 3 symptoms you have to ask in negative history to rule out that diagnosis.
Yes.
Then the history is related to the complication of that particular disease.
Complication.
Complication is what? If suppose you are expecting prostate or BPH or CA prostate, so what are the possible complications? He may have hematuria.
Yes,
He
sir.
may have
Urinary tract.
he may have a recurrent UTI.
Yes, sir.
He may
Hematuria.
have a cross dilated upper tract and renal failure. So signs and symptoms of renal failure. He may
Yes.
have a bladder stone. So suprapubic pain, frequency, stangury. He may have a VUJ stone only, no prostate. Then he may have CA prostate. Then metastatic, locally advanced symptoms of locally advanced CA prostate, symptoms of metastatic CA prostate. So if when you are telling symptoms in one line, examiner must understand he is asking about some, for example, tuberculosis of the bladder. For example, tuberculosis can also be possible. Here is the frequency is the only symptom. So if you tell like this, examiner will come to know, okay, you are asking about tuberculosis, you are asking about diabetes, you are asking about bladder stone, you are asking about CA prostate, you are asking about BPH, you are asking about neurogenic bladder. So negative history is to show your cleverness and knowledge to the examiner. So go ahead, Abhishek.
Agree.
Yes, sir. So, sir, in negative history, we would like to first find out about whether he's had any symptoms, LUTS symptoms in the past or not, whether he's had any episode of acute urinary retention, whether any intervention was done previously, whether he has ever been catheterized, whether he has had any previous instrumentation or surgery of the genitourinary tract. If there was a acute urinary retention, what management was done? Was it characterization of the urinary retention is important? Is he on any kinds of drugs or like anticholinergic or sympathomimetic drugs? And whether he has had any previous trauma to the spine, sir, or spinal surgery, sir, after which this has started occurring. And thereafter, sir, in history of complications, we will ask, sir, whether he has had any fever or suprapubic fullness and dysuria associated with the symptoms. Then whether he has had hematuria, whether he has had hematuria and constitutional symptoms associated with these lower tract symptoms, or he has had any kind of bony pain associated with these symptoms, sir, and chest pain, cough, or bony pains are associated with symptoms. Yes, sir. I'll proceed in that sense, sir.
Yes. And if you are not told, then history suggests a renal failure.
Renal failure, yes, sir, as complication, right?
So it
And
always,
then,
always ask about it.
also family history, sir. Family history that whether it's first degree relatives like brother and father are have suffered from any CA prostate or not. Whether he's been taking any kind of injectable medications pertaining to yes, sir, injectable medications which may be indicative of CA prostate, sir. That sense, sir. Yes, sir.
Okay. So go ahead, Vivek.
The negative history, sir, as he has said, no history of urgency, urge incontinence, constipation, nausea, vomiting, flank pain, or any fever, lithuria, pyuria, hematuria, or any decreased urine output, swelling of the lower limbs, or facial puffiness. No history of lower limb weakness, trauma to the lower back or spine, surgery. No history of recurrent urinary tract infection, urethral discharge, or any urethral instrumentation. There is no history of any chronic cough or sinus medications or AUR, and there is no history of any metastatic symptoms.
Okay, go ahead.
So the patient has a significant past history. The patient was evaluated outside as a case of bladder mass with enlarged prostate with a chronic bladder outlet obstruction with right VUJ cal in 2019. The only symptom was pain lower abdominal. At that time, 2019, he was evaluated. On evaluation, CT abdo-pelvis was done in 2019.
In 2019.
Yes, sir. Which was suggestive of well-defined heterogeneous enhancing.
Wait. Abhishek or
Yes.
Yashir, what more things you want
Yes,
to
yes.
ask about event in 2019?
Sir, about the event in 2019, right, VUJ Cal, what was done about the bladder mass, sir? What was the biopsy report of that bladder mass? Then enlarged prostate with right VUJ Cal. Yes, sir. Sir, then sir, how long was the patient admitted? Was he advised anything after that surgery or not? How long were the tubes there, sir? And yes, sir. Was he advised any follow-up in the future, sir? And after that, prostate enlarged with the bladder outlet. Yes, sir. And what is the what is the frequency of symptoms after this event, sir? Has it progressed? Has it been the same, or has it reduced, sir?
Okay. Vivek, go ahead.
Yes, sir.
What was
CT,
the
CT
history for the
abdomen.
prostate also?
Yes. Yashir, bolo.
Yes, sir. Well-defined
Was any
heterogeneous.
surgery done for the prostate or
No, sir. No, sir. No surgery was done for the prostate. A cystoscopy was done, where a biopsy was done. A bladder mass biopsy was done, which showed detrusor muscle tissue and prostatic tissue showing mild atypia, no malignant cell. So there was no documentation of what surgical procedure actually took place. Only biopsy report was there.
So he came with biopsy report done in 2019, and this is the biopsy report.
Yes, sir. And the cytology was negative for any malignant cell.
In 2019.
Yes, sir.
Okay.
Sir, other than this, there was significant past history of tuberculosis 20 years back, for which the patient took ATT for only 3 months. He did not complete his course.
So Yashir, just
Yes,
summarize the thing.
sir.
Just
Sir,
summarize the
so
thing.
in this case, and this 60-year-old man with the history of presently having the history of the LUTS has significant history in the past of bladder carcinoma with history of this genitourinary tuberculosis diagnosis, for which most probably the patient has left the treatment after 3 months only.
Okay. Vivek, he has a genitourinary tuberculosis or pulmonary tuberculosis?
Pulmonary, sir. It was a pulmonary tuberculosis, sir, 20 years back.
Okay.
Yes, sir. Patient did not have any hypertension,
Mhm.
diabetes, or asthma. On personal and surgical history has been said. There was chronic. He was a chronic tobacco addict for last 20 years. No alcohol addiction. No significant family history. Patient's sleep appetite habits were normal. Bowel habits were normal. No history of any allergy for any drug intake. Examination, sir.
Wait. So this is the past history. Exact details about past history is not too much available, except that histopathology report of bladder biopsy, and now he is presented with frequency of the urine. So significant past history, pulmonary tuberculosis 20 years back. So he may have a urinary tuberculosis now. That is the one problem. He had a VUJ calculus. That calculus is removed or not removed, we don't know. So he may have urinary calculus and present as a frequency right now. So again, VUJ calculus is another differential. He may have a benign enlargement or malignant enlargement of the prostate. He may have a PA bladder and storage symptoms. So exactly we don't know now what is there, because about 2019 there are 3-4 diagnoses in the past, and exact details is not known. So what are the things to be expected in a clinical examination?
Yes, sir.
Bolo, actually bolo. Frequency. Patient presented with frequency per abdominal examination. What are the possibilities? What are the possible findings? Yashir.
Hello. Yes.
Hi, Yashir, bolo. Yashir, go ahead.
Sir. Sir, in the examination only, sir. Actually, sir, my this is meeting now. It's repeatedly going on and off. I don't know. Please. Hello.
Okay, Abhishek, go ahead.
Sir, para-abdomen examination may be essentially normal, excepting, sir, there may be suprapubic fullness which may be seen because of chronic retention of urine, sir. Otherwise, sir, on inspection, we would look for any, with the shape of the abdomen, any scar sinuses, dilated veins, or any hernial orifices. Other than that, on palpation, sir, our focus should be on the suprapubic region, sir. Any suprapubic fullness, any suprapubic dullness, any suprapubic pain is there or not. The renal angles, sir, the status of the renal angles, bimanual palpations, whether any mass is palpable or not, although unlikely, sir. But then after that, we would complete our examination with the digital rectal examination, sir, to feel for the prostate, the consistency, tenderness, whether it is tender, non-tender, what is the surface of the prostate, what are the landmarks, and then, sir, whether the overlying mucosa is free or not, any nodule is felt or not on DRE, sir. Yes, sir. That way we should proceed with the examination.
And genital examination.
And genital examination.
Genital.
Okay.
Accordingly, sir, general examination was done, which was conscious. Patient was conscious, cooperative, oriented to time, place, and person. Karnofsky score was 90%. Afebrile. Vitals were stable. Respiratory rate was 18 per minute. There was no pallor, clubbing, icterus, edema, or lymph nodes. Spine examination was normal. Per abdominal examination, inspection, so everything was normal, nothing significant. Palpation, there was no renal angle tenderness or fullness and no organomegaly. Bladder was not palpable. On percussion, there was a tympanic note over the abdomen, and percussion over the renal angle was non-tender. Bowel sounds were present. On local examination, the penis was uncircumcised with meatus being normal. Focus neurological examination was normal. Bilateral testis was normal on palpation. A DRE was done where the perianal sensation was normal, anal tone was normal. Grade 4 prostate, non-tender, firm in consistency, no nodularity. Rectal mucosa was free and mobile. No perrectal or peranal lesion was detected. No melena or bleeding PR.
Okay. So this
All-
is the finding.
Yes, sir.
So except 4 prostatomegaly. Except grade 4 prostatomegaly, no other positive finding.
Yes, sir.
So, at the end of clinical examination, what are your differences?
The first would be the enlarged prostate, bladder outlet obstruction because of the prostate. It can be benign or the malignant prostate. And second could be, sir, bladder. No, sir, it can be the prostate will be the first diagnosis. Second, we can keep the genitourinary, this tuberculosis and bladder malignancy. We can keep at the third number, sir.
What are the signs and symptoms of genitourinary tuberculosis?
The patient has the more of the storage symptoms and mostly
Except
the frequency.
does he have any other symptoms?
No, sir, but having a previous history, being in having history of taking ATT in the past for only 3 months, he can have also relapse of the tuberculosis and keeping that.
Chances of hematuria, what are the urinary tuber start from below and go up, or it start from kidney and come down? Okay.
Sir did not ask you why you are suspecting tuberculosis. Sir is
Yeah.
asking you what are the symptoms of tuberculosis.
Simple, because here there is enlarged prostate. If you told like enlargement of prostate, benign oblique malignant one, enlargement
Yes,
of prostate with stone is 2, bladder oblique VUJ stone is 2, and still he had history of some bladder malignancy, and we don't know.
Yes, sir.
So be enlargement of prostate with associated bladder malignancy 3, and lastly, as he had a history of pulmonary tuberculosis, he may have a benign enlargement of prostate with urinary tuberculosis.
Urinary tuberculosis.
So that diagnosis is lost. What is common? The sequence is very important. If you told
Sequence,
first
yes.
diagnosis as a enlargement of prostate with genitourinary tuberculosis, then whole Vava will go towards tuberculosis.
Yes, sir.
So how will you proceed? These are the 4 differences right
sir.
now. In front of you, these are the 4 differences.
Sir, I will like to go with first with the routine investigation. In this case, I will like to go with CBC, renal functions, plus serum PSA. Plus, I will like to sir add this urine for cytology and chest X-ray in the investigations. Chest X-ray to start with the evaluation for tuberculosis and urine for cytology to start with the investigation for the bladder malignancy.
Abhishek, are you agreeing with his concept?
Sir, yes, sir. Apart from the routine investigations, I would also like to include an ultrasound of the KOB region, sir, and uroflowmetry, sir, to evaluate the lower urinary tract symptoms. Ultrasound KOB will give us the status of the prostate, sir, post-word residue, if any, if there are any stones in the bladder, sir, what is the status of the bladder wall, sir? It has been mentioned that he has a diverticulum also, sir. So that
Where
will
it
be
is
correct,
mentioned?
sir, in the previous.
Yeah.
So, sir, that will be characterized, and yes, sir, on the basis of that, we can proceed, sir, other than the routine blood investigations, what you mentioned, sir.
CBC and urine routine is for infection.
Urine.
Serum
Yes, sir.
creatinine is for renal function.
Yes, sir.
Ultrasound is for assessment of bladder and prostate. Again, for assessment of prostate, PSA. Again, for assessment of bladder in the past, they are suspecting cytology. Again, for assessment of pulmonary tuberculosis test. So these are the primary investigation to be done, and these are the causes. Why you are doing? Now, go ahead with give them the reports.
Urine
And
analysis.
uroflowmetry. Obviously, again, uroflowmetry. Abhishek is told already.
Yes. A urine routine and microscopy was done where the pH was acidic, albumin was absent, sugar was absent, RBC were 4 to 5 per high power field, pus cells were 8 to 10, bacteria nil, cast and crystals were absent.
8 to
Baseline
10%, Abhishek.
Yes, sir. Sir, yes, sir. So we should go ahead with the urine culture and sensitivity test, sir.
Yes. Okay, go ahead, Vivek.
So the baseline investigations were essentially normal with creatinine being 0.8. Blood sugar was also normal. A urine culture showed no growth of any organism. Urine cytology was done, which was negative. Total PSA was initial total PSA was 11.72 nanogram per DL.
And chest X-ray.
Yeah, sir.
They were
Unfortunately, chest X-ray was normal. We don't have the films here, and uroflowmetry, sir, the report was missing.
So
Yeah.
uroflowmetry is obstructed or poor flow. Suggests a poor flow.
Yes, sir. An ultrasound was done of the kidney ureter bladder region, which showed right kidney normal in shape, size, and CMD, 11 mm cal in the mid pole with no evidence of hydronephrosis or hydroureter. Left kidney was normal, no cal, no HNHU. Bladder, there was a 17 mm cal in the right VUJ, 8.5 into 4.9 into 4.6 mm solid mass at the base of the bladder with minimal vascularity. Plane between the mass and the prostate is indistinct. The pre-void, the PVR was 157 by 690 and a prostate of 84 gram.
That's it.
Yes, sir.
These are the reports available.
Yes, sir. So the patient is having solid mass at the base of the bladder. Likely, this bladder malignancy would be a recurrence if we have the previous operative notes to know whether it is the same site or not. And second thing, we have what is in 17 mm calculus at the right VUJ. If
11 mm.
this may be the same stone, 17 mm calculus at the right VUJ. So the patient has likely in bladder carcinoma with the right VUJ stone, which may be likely that previously this thing was not operated. The patient has also said enlarged prostate, which is 84 grams, and on DRE being grade 4. So the total diagnosis will be an enlarged bladder outlet obstruction with enlarged prostate.
Reorganize yourself. Okay. So here again, the problem is mass at the bladder base. 1, 2, increase in PSA. That is more than 11. And renal stone. These are the 3 problems ultrasonography is suggesting towards. Okay. And clinical presentation with significant post-void residue and poor flow on the uroflowmetry. So that mass is whatever the mass is, it may be arising from bladder or it may be arising from prostate. That is obstructing, that is causing the bladder outlet obstruction. Itna to pakka hai. Okay, it is a poor flow, uroflowmetry, and symptomatology. Now, what next? Urine cytology already told negative. Culture is negative.
Yes, sir. Want to characterize the mass, sir, for characterize the bladder mass and the exact anatomical distinction between the mass and the prostate. We do a CT urography, sir, triple phase contrast enhanced, and which will also give us characterization of the stone, sir, the 17 mm right VUJ calculus. And other than that, sir, after this, sir, an MPMRI of the prostate to assess the locoregional
First you want to go ahead with CT scan.
First,
CT urography, yes, sir.
Abhishek,
Yes, sir.
you
Yes,
should
sir.
do one after another, na?
Yes, sir.
Step by step.
Correct?
Go step by step.
Yes.
So first you do CT scan. na?
Yes, sir.
You see the CT scan report and then you decide.
sir.
This is the CT IBP was done. This is the oral phase, the unenhanced phase. I think these were delayed. Shit, yeah. This was the arterial phase, sir. This was the delayed phase, sir. So these were the three phases.
Okay.
Should I repeat it, sir?
So, no. Can anybody read whatever possible?
Abhishek, if I was you, I would have said that I have
on
not
the
seen the plain
CT,
film.
Sir?
Huh?
Yes, sir. I'll.
Abhishek, if
yes,
I
sir.
was you, I would have said I have not seen the plain film.
Yes, sir. The
Okay.
plain film was missing.
Yes.
You should have said that.
Right, sir.
How can you comment on enhancement? How can you comment on stone? You want to compare it, no? You
Yes,
should
sir.
see
Yes,
that
sir.
it is
Yes, sir.
how on CT. If the contrast is given directly, how you will appreciate stones?
Yes, sir. True, sir.
All small things you have to keep in mind every time.
Agreed. Okay. Vivek, run once oral phase.
So the oral phase was
नहीं ये है ना
ये शायद delayed.
डिलेड कैसे रहेगा वो तो उसमें दिख रहा नहीं ना कुछ
सर वो दिख रहा है वो delayed phase है सर ये.
Delayed है. Yes.
तूने ओरल लिखा है ना ऊपर ठीक है
Yes sir.
ठीक है these are the films available whatever possible can anybody read please
Abhishek, you can just answer whatever you have seen.
Yes, sir. Sir, in the CT, sir, section, sir, it can be seen that there is a large the kidneys appear unremarkable, sir. The kidneys ureter appear unremarkable. A right side view calculus can be noted, sir. And on moving on to the bladder, sir, there is a large filling defect, unenhancing filling defect, which can be seen occupying the posterior wall of the bladder. And there is also a diverticulum which can be seen on the bladder, so right lateral wall. There appears to be some thickening of the bladder wall also. And yes, sir. Please proceed.
And how is the mass? Mass is irregular or it is smooth?
mass has smooth margins, sir. It is
It looks
unenhanced.
smooth, sir.
Yes. Right.
Yes, sir.
Okay.
Yes.
Without seeing the urographic film, reconstructive film, stone in the or serial axial images, it is not possible to comment on. It is a Veuge stone.
Okay, sir.
Okay, so it may be Veuge stone, it may be stone in the ureterostele, it may be stone in the diverticulum, it may be stone trapped behind the recess of the intraprostatic protrusion of the prostate. So anything can be possible.
Right.
This is one thing. Another thing is the mass arising from the prostate probably or at the base of the bladder is reaching right up to the dome of the bladder, with having a multiple bladder diverticula and thickening of the bladder. Small, if you see carefully, there are small bladder diverticula. So, विवेक रिपोर्ट बोल दो, क्योंकि पूरा फिल्म नहीं है तो इसके ऊपर ज्यादा कुछ बात नहीं कर सकते. रिपोर्ट.
The report was suggestive of right kidney 9.5 into 4.8 centimeter. A 10 mm cal of 930 Hounsfield unit was in there in the mid pole. Left kidney was 9.2 into 4.7 centimeter with no hydronephrosis or hydroureter. The ureter was normal. Bladder was distended with thickened wall. There was a polypoidal mass of 7.3 into 5.2 into 4.8 centimeter from the base of bladder, sharing same characteristics and enhancement pattern as prostate, suggestive of median lobe hypertrophy. There was also a 15 mm cal of 1200 Hounsfield unit seen in a diverticulum from the right posterolateral wall. Prostate was grossly enlarged around 76 cc and together with its hypertrophied median lobe indenting the bladder base and intraluminal, it is around 130 cc total.
Hello.
Yes, sir.
This is the story. This is the report of CT scan.
Yes, sir. Yes, sir.
So, what are the questions in your mind after seeing the CT scan?
Sir, since
Most
the
likely it looks
yes, sir.
medium lobe hypertrophy.
Yes,
which
sir.
is rotated into the bladder.
There is a median lobe hypertrophy plus two calculi. One in the right, one in the right kidney mid pole, and another one is at in the diverticulum, the right posterolateral wall. Both are hard stones. More than one is almost 1,000 Hounsfield, other is 1,200. So this
130 cc of the prostate.
yes,
Two,
sir.
three important things. Still L1.2 PSA.
Yes, sir.
Is it normal?
Sir, it is beyond the diagnostic gray zone, sir. So
130 gram prostate. So the rise in PSA is related with the age of the patient, size of the gland. Is it so? 130 gram, is it normal or is it still high?
So for 130 grams, it can be said like normal, sir. But then it is beyond the diagnostic gray zone, sir. So we must proceed to evaluate that, sir.
So how will you evaluate this?
Sir, we'll do an MPMRI of the prostate, sir. Evaluate the locoregional extent of the prostatomegaly and and after that do a truss guided biopsy, sir.
Any other way?
Cystoscopy and biopsy. You can proceed with the cystoscopy and biopsy.
Which biopsy?
The mass which as per the CT and sonography is from the bladder base.
So CT is directly saying that this mass is having a characteristic similar to the prostate. So there should not be any confusion in your mind that this mass is arising from the bladder. PSA is raised, cytology is negative. So still, there is a role of diagnostic scopy. If you want to you can to differentiate between the bladder mass and prostatic mass. But the discussion is going on towards the PSA. The PSA is 11.2. So to differentiate, is it malignant prostate or benign prostate? Abhishek want to do a MP-MRI. I am asking any
Right,
other
sir.
way. Shanti is telling PSA density in chat box.
Sir, but that again by definition, sir, PSA is beyond, sir, 10, the diagnostic gray zone, as they say. And sir, so for that, sir, we'll go with biopsy upfront, sir.
So you
Although
want
for
to do thrust and biopsy, you want to do MP-MRI and fusion biopsy, or you want to do PSA density by just dividing the PSA by prostate volume.
yes, sir, we can do that, sir. Matlab,
Frustrated biopsy would be the certificate.
guided biopsy will be.
And we can also do, sir, this, we can do finger guided biopsy also because the prostate is grade 4. So
Can you just calculate the PSAD? And tell me how you are calculating.
Yes, Yasir.
so we have the volume.
So PSAD is equal to PSA divided by prostate volume.
Volume. So 11 by 1.
So 11 divided by 130.
Yes, sir.
Yeah, someone has asked whether can we go directly with the TURP or removal of the prostate.
Devashis Chobe is telling absolutely wrong thing in chat box.
Because if it is a malignancy, the
Because
management is totally different.
TURP cannot be used to diagnose the malignancy of prostate. Because 75% of the malignancy of prostate is peripheral zone. And TURP, we are not restricting the peripheral zone until and otherwise it is arising from the transitional zone. Then only, or if it is extensive malignancy involving the urethra, then only it is possible to diagnose the CA prostate with TURP. So TURP is doing a TURP for diagnosis of malignancy is wrong. Go ahead, Yashir. I am asking PSAD.
Sir, this PSA by the volume that around will come in this case around 0.01 like that. So
What is the normal PSAD? L1 divided by 130. How much it is?
Yes,
0.
almost 0.01.
Okay, if it is 0.0, what is normal PSAD?
0.15
to 0.2 nanogram per ml per cc.
Yes, sir.
Okay.
Yes, sir.
So it is less than normal. 0.01 means less than normal, na?
Yes, sir.
So what it suggests?
So what does it suggest?
It is more, sir, for this size of prostate, it could be normal.
Yasir, for this
normal.
size of prostate,
It
this
is
PSA
suggestive
is normal or not?
Normal and
nature of the
benign disease
prostate.
only, sir.
Yes.
See,
So
you can, Yasir, you can always say that, sir, yes, PSA density, as per PSA density, these values are coming within normal limits. But if you are in doubt, you can say that I will like to do MRI before doing my removal of the prostate, just to rule out whether there is a malignancy or not.
Yes.
So if you are telling in exam MPMRI with PhD, because PhD is improves the negative predictive value of pyrad. So for knowing the period score, you have to do MPMRI. But as PhD is suggested to us benign nature, doing a MPMRI is plus minus. Can be defended, cannot be defended. Okay. So
Yes, sir.
tell me importance of intraprostatic, intravesical
मुझे
protrusion of
पूछने
the
थी you
lobe.
also know me. I don't expect anything much from any girl.
Hello?
Who is talking on phone? Please,
Show me.
please mute yourself.
Arey, see what I expected from you.
See.
What means just nothing. No, see I don't expect anything from any girl.
Mr.
Hello?
Sachin,
Sachin, mute
Who is
yourself.
talking?
Sachin, mute yourself.
yeah. Okay. Yes, go ahead.
So for the so there is hypertrophy of the median lobe that has that's involved into the bladder.
The importance of intravesical protrusion of the median lobe. Follow.
Abhishek, can you tell us?
Sir, it will cause, sir, it will cause reduction in effective bladder capacity, causing storage symptoms, sir.
Any other important point?
It can cause obstruction of the ureteric orifices.
Yes, sir.
So what are the importance of intravesical protrusion of prostate? So number one, it will be very near to the ureteric orifices.
Yes.
Second thing, you have to remove the intraluminal part of the prostate in any of the surgery,
Yes,
right?
Yes,
Third,
sir.
as you
Yes,
said, it can reduce the capacity of the bladder, and hence the chances are very high that you patient may have post-op frequency, as well as he may have urinary incontinence. So you have to explain the
Is medical
consequences of your
treatment
surgery.
is medical treatment work on intravesical protrusion?
Abhishek,
sir.
No, sir, I'm not sure. No, sir, it
So-
does not. No, sir, it does not.
Because the alpha blocker what you are using is they are made to relax the smooth muscle at the level of bladder.
Bladder okay.
So that role of alpha blocker is work.
Yes.
If you are using only dutasteride, yes, it can help in reducing the size of the prostate, but it has to take for longer duration. This is one point. Another point, intravesical protrusion act like a ball-valve mechanism.
yeah,
And
Yes, sir.
obstructive symptoms is more, chances of nearby retention is more, chances of need of surgical treatment is more. So this is the importance of intraprostatic extension. Now, define what is meant by giant prostatomegaly.
Sir, prostate measuring, sir, more than 80 cc is considered as
no,
What is meant by giant?
150, sir.
What is meant by giant?
giant.
150, sir.
भैया 150 को तो लोग आजकल TRP कर दे रहे, theoretically allowed नहीं, लेकिन TRP कर रहे 130. I am coming to then chat box after that. Just tell me what is meant by giant prostatomegaly. लिखो, giant prostatomegaly is the massive enlargement of prostate more than 500 grams. More than 500 grams.
We have reported 2 cases and presented in USI 650 grams of prostate, which you can palpate suprapubically.
Agree. So this is about the enlargement of the intraprostatic extension of the prostate. Chat box. I am coming to chat box. Okay, in between. Sir, how the diagnosis of TA is going to change our management? Patient is having.
Yeah, I will answer him. Beta, first of all, it is,
test if IPS is 18, he always will require a TURP. Yeah.
Yeah, the first of all, it is very important to diagnose whether it is a benign or it is malignancy, because first of all, in the younger patients, the line of management will totally differ. And second important thing is, as Dr. Gite has said, that in such cases, now if you do TURP, you are not going to remove the whole prostate, even adenoma. You are going to just do a channel TURP. And when you do a channel TURP, 90% chances are there that you will not get malignant tissue. So you will not treat this patient properly. So as far as this case is concerned, I don't think that you are justified in doing TURP, because you are just going to relieve some symptoms, but you are not treating the disease.
I will make his concept clear by another way. Suppose this patient has a malignancy, and you are telling it your management is not going to change. PSA is 11.5. Malignancy is suppose some as a localized prostate malignancy. Is the management is still TURP or RRP?
No, sir. Then the management will be
obviously
RRP.
it is RRP.
Yes, sir.
Another thing. Again, I am telling, for diagnosing the CA prostate, doing a TURP is not a ideal. That is not the choice. That's all.
In the classification, it is given because that is incidentally detected.
Suppose
Incidentally.
this patient had a metastatic CA prostate, diagnosed already on any suppose CT scan. Yes, in such situation, the treatment is not going to change. So either it is a channel TURP or conventional TURP. Still, doing a TURP with a bladder stone oblique VUJ stone for 130 gram prostate, theoretically wrong option. So hope that डॉक्टर जो भी है उनका concept clear हो गया हो.
Suppose you are not suspecting malignancy and the patient had TURP, then that classification T1C comes. That is different. Yes. You should never tell in exam that you will do TURP and detect malignancy. Get this concept very clear now and for all. Don't make that mistake. It has to be either MRI or biopsy.
Okay.
Abhishek.
So
yes, sir. Heard, sir.
Yeah.
CT report already over. Now PSA density is over and size of the gland. Okay. Final diagnosis. Abhishek.
Sir, one more thing. What you said. Many like in Amsterdam, the university guideline was there. 125 gram prostate, you have to do open millings. That is why sir is telling, don't go and say 150 gram, you will do prostate with bladder stone. In fact, that is the case where you can say that you will do Freyr's prostatic.
For 130 grams prostate, sir. Yes, sir. Open will be ideal, sir.
No. Sir is giving a hypothetical situation.
Okay.
That there is a large gland plus there is a bladder stone. So then you can defend by saying that you will do Freyr's and not millings. You understood? Because you have a bladder stone, that is why.
Yes,
so in the exam, you have to use your brains. Just because you are saying millings, it doesn't mean you have to say millings. If there's a bladder stone, then you say, sir, I would prefer to do Freyr's prostatectomy because I can tackle the bladder stone as well.
Right.
Another finding in CT report is 15 mm stone seen in the diverticulum, right posterolateral wall. So this patient has a 130-gram prostate and stone in the diverticular. So this is probably a final diagnosis with raised PSA.
There are some very important findings in this CT scan,
that
including
means-
the way the mass was appearing so smooth. Gaurang Shah sir asked that question. Is it appearing very smooth? Normally, bladder mass will never appear like that.
Yes.
And the second important thing is Dr. Gite told you, okay, don't comment on ureteric stone unless and until you see the sagittal field, all the total reconstructed. So in this case,
And,
you know, so you as you
and
can see,
plain
it is
film.
not in the ureter.
Plain film also. Always ask for plain film.
Diverticular.
This is how exam case will come. It is not straightforward case. There is stone, there is diverticulum, there is a large prostate, there is
Now,
previous history of some biopsy.
just tell me what is the natural progress of the benign enlargement of the prostate disease. Enlargement of the prostate disease, natural progress. So 18 gram to 20 gram is normal. At the age of 40 years, prostate started enlarging and enlarging and enlarging. So what will happen?
There will be
Anyone?
complications
It
secondary
is
to
like describing the thyroid.
Don't go to
the
complication, man. You know
complications
prostate is enlarging. What are the changes
secondary to
happening in the bladder? What is the
yes,
collagen
sir.
deposition? This, that, or
In
like that you have to tell.
yes, sir, the in bladder the chains are there are trabeculations in the bladder. There can be the diverticular formation in the bladder, and in the upper urinary tract there can be
Yasir,
chains in the
Yasir.
upper urinary. Yes, sir.
Yasin, you please classify. Okay. There are two things which are going to take place. One, the enlargement of the prostate will cause obstruction. So there will be a functional problem as well as there will be a anatomical. Understood? So first you
Yes,
can
sir.
describe what happens to the bladder. And second is what happens in the symptomatology.
So in the bladder there is the diverticular hypertrophy with trabeculations of the bladder, and
First,
after
what
that.
happens?
First, basically bladder tries to come over the obstruction due to the prostate, and secondary to that there is hypertrophy in the detrusor muscle.
So when there is an obstruction, first what happens to the bladder?
Compensatory hypertrophy
Yeah.
of the
Fine.
detrusor.
So
And then
bladder try to overcome the resistance provided by the prostate.
Yes.
It will end up into hypertrophy of the detrusor muscle. When there is a persistent increase in the intravesical pressure, then there is what happen? Herniation of the small bladder mucosa into the detrusor muscle.
Detrusor muscle.
That is ejaculation and diverticulation. First trabeculation, then ejaculation, and then diverticulation. So these are the.
Yeah. So now next what happens to the ureteric orifice?
And if still prostate is untreated, it will end up into formation of the bladder stone, formation of the bladder diverticuli, formation of the recurrent, having a recurrent UTI, and chances of having a cross hematuria, then end up into the bilateral adenephrosis, then finally renal failure. And end of the process of PEP is end point is
renal failure.
acute urinary retention.
Okay.
Yes.
So this is the end point of that disease. Nature of the disease end point, AUR. Untreated disease end point, renal failure. Okay. So now 130-gram prostate and diverticular stone. I will go back again to the chat box. Okay, sir, thank you.
Yeah.
Also, there are no
See, no, there are two questions. One, someone has asked whether can we do TULIP and which will help us in even removal of the stone. So first of all, we have not come to the management part. So when we come to the management, we'll discuss everything. That is number one. And number two, what was the second question?
Sir, please throw light on whether we should do PSA routinely in all cases of BPH, and while presenting a case of BPH in exam, what should we answer whether to do PSA or not? Yes. So doing a PSA after the 50 years yearly once is indicated as per all guidelines as a screening protocol. And after 45 years in a patient having a history in the family of a prostate till age of the 75 years. Okay. So telling a PSA as one of the investigation in presenting a case of a prostate oblique BEP is not wrong thing in exam.
Yeah, I will say that in case if the examiner they ask you, we can always say that as per the EUA guidelines, they are not doing PSA unless and until the patient asks for that, or when they are doing rectal examination and they find some hard nodule, they will ask for a PSA. But as far as India is concerned, there is no protocol as such, and we are routinely doing as Dr. Gite has suggested you. So in exam, normally we always ask for PSA.
Another question by Devashish Chobe again, the channel TURP and bilateral archidectomy. Yes, if patient is on catheter with secondary to the bladder outlet obstruction caused by malignant metastatic prostate, and if you are planning for bilateral archidectomy, two ways of theory. Few people will do just a bilateral archidectomy and wait for few weeks or months, and in such situation 50% of the patient pass urine without doing the TURP. That is one way. Another way, if you are expecting if this is a severe tight obstruction, large gland, by doing the archidectomy, that is not going to reduce in early period or short duration, then a patient don't want to be on the catheter, then channel TURP. So doing a channel TURP with bilateral archidectomy is not wrong option. But if examiner tells any other options available, patient don't want channel TURP, then yes, sir, I will go ahead with bilateral archidectomy, wait for 3 to 4 weeks, and in such situation, 50% of the patient pass the urine without doing the TURP.
So regarding PSA, like how just I'll throw some light. What you said was absolutely right. We have to do the PSA according to guidelines. So like Gaurang Shah sir also said, according to European Union. So there they have this thing saying that their patient should be well informed. So you have to mention that, and that PSA usually according to guidelines will do more than 50 once a year, and more than 45 there is a high risk case. Secondly, there is family history. Third, if at all you're doing the PSA, you have to keep the patient well informed as to why you're doing, and it's a screening test. And last, positive DRE is irrespective. When you have a positive DRE, you must do PSA and you have to do translated biopsy. So you must use that word positive DRE.
Okay, then
and
another
then you
question.
say PSA in follow-up. So when you have malignancy, then you use PSA in follow-up. Either you have done treatment, or you have done radical prostatectomy, or you have done radiotherapy. Then you will do Nadir PSA, or then if you're giving hormones, you will again see what is the response. So that is the role of the PSA post-treatment.
So what is the next plan, Ashir?
So
just enlist the options available.
The first option will be Freyr's open prostatectomy with this dealing with the stone in the diverticular, followed by this for the stone in the, that can be dealt separately for the stone in the kidney.
Yasir, I will ask you only one question.
Yes, sir.
Yasir, I will ask you only one question.
Yes,
How often you will be able to see stone in the diverticulum, or you will be able to find out the diverticulum and locate a stone by cystoscopy in such cases?
Cystoscopy, sir, it will be difficult to localize the stone because it is close to the right, in the right posterior lateral wall, close to the VUJ. And prostatic, this intraprostatic, this intravesical prostatic protrusion is just encroaching that. So once we put the cystoscope, it will be, sir, very difficult to localize the stone in the diverticle.
So again, in exam, Viva may go towards the formation of stone in the benign enlargement of prostate. So what are these? You read, please. Okay, what are the causes of formation of stone? Stone may come from up and drop in the bladder and enlarge at that
Primary and
increase
secondary.
in size. The primary, secondary, and migratory. And these are the three pathologies of bladder stone in the enlargement of prostate. So obstruction, recurrent UTI, formation of stone. This area also one theory for formation of stone. So we will discuss that in different class. But the treatment option.
Yasir, you just tell us what are the different treatment management
Options available. अगर किसी ने पूछा
sir,
एग्जाम में, what are the treatment options available?
first is the
मैं
open
तो 3-4 बोल
prostatectomy.
दूंगा अभी फटाफट, तुमने बोल दो 2-4 तो कम से
Open
कम बोलो.
open prostatectomy.
ओपन प्रेस
Prayers,
प्रोस्टेटेक्टमी करने के पहले अभी मैं
prayers
तुमको ओपन प्रेस
prostatectomy.
प्रोस्टेटेक्टमी पे पूछता हूँ. यासिर, you want to do a
Yes, sir.
scopy before doing the open prostatectomy, cystoscopy, or you don't want to do?
On the same
In this
once we
patient,
plan
in
the
this patient, you want to do
Yasir, what
cystoscopy.
Dr. Gite is telling you that whenever you say open prostatectomy, please add, I will like to do checks, I will like to do cystoscopy followed by open
Followed.
prostatectomy.
yes, sir.
Please don't say open prostatectomy. Say I will do cystoscopy followed by.
Cystoscopy followed by the
So why you want to do
open
cystoscopy?
prostatectomy.
Yeah. And why you want to do scopy?
Because first thing was we had I had a confusion regarding whether the mass is not having a history of the bladder malignancy in the past. So I would like to basically do one kind of check cystoscopy to check whether this mass is from the bladder or not. So for the bladder screening, I will do the check cystoscopy. Plus, I would like to know how far it is from the ureteric orifices.
So Nasir, doing a scopy with rigid scope in such type of patient is not easy job, because that intravesical extension is reaching right up to the dome,
Don't worry.
and then again seeing the stone behind that intravesical protrusion
Yes,
in the diverticulum is literally not possible.
yes, sir.
So if you are flexible scope, then it's okay. If you can go and see the diverticular opening, then size of the diverticular opening, small hai, bada hai, then size of the diverticulum and size of the stone inside, coming out, not coming. Okay, if you open and if your finger is not going inside the diverticulum, then how you are going to remove the stone? And if you open the bladder and if you first try to remove the stone, your finger will not reach to the diverticulum due to that intravesical extension of the prostate.
Yes, yes.
So these are the intraoperative difficulties. So for ruling out all these things, you have to do a scopy with flexible scope or scopy, at least rigid scope. If it is not too much enlarged, if it is bilobar prostate, yes, it is possible with rigid scope. Yes. Okay, so breast prostatectomy with stone removal is one option. Another option,
We can do, sir.
transvesical laparoscopic oblique robotic breast prostatectomy with bladder stone removal is another option. आपके पास नहीं है लेकिन हो सकता है ना. It is described. मेरे पास भी नहीं. ठीक है.
Yes, sir.
Any other option?
Yes, sir.
Someone is already telling कि thulium prostatectomy with bladder stone removal. If he is expert in doing the surgery, laser surgery, yes, it is another indication at least for 130 grams.
But in laser, we will not get the biopsy.
Then for आपको उसके QRP उसके साथ ऐड करना पड़ेगा थोड़ा.
Okay.
Yes, you can do HOLEP also, you can do THULEP also. These are the indications.
Agreed. HOLEP, THULEP, robotic, इसके बाद में laparoscopic and open. These all are options. What you will do if examiner asks, I will do open fresh prostatectomy. Simple answer. There is no any. तुम्हारे पास रोबोट होता होगा तो भी नहीं बोलना. Unnecessary वो रोबोट में अटक जाएगा इधर उधर कुछ तो ऐसा ही हुआ. I went to Ahmedabad and there everything is done. People are doing by the laparoscopy and I asked one simple question. Can tell me the steps of robotic radical prostatectomy RRP. He is not able to answer that question. So basic things, whatever is happening in the India, in majority of the centers, that you know, that you should know, you must know. आपके पास रोबोट होता है तो अच्छी बात है, वो आया तो और अच्छा है, लेकिन बेसिक आना जरूरी है.
Yes, sir.
So Yasir, you just tell me that how many urologists are doing TURP? So you will say almost everyone.
Yes.
How many are able to do open surgery? Compared to that, how many can do laser, that is HOLEP and THULEP, and how many can do robotic? So your answer will be that even if you are not trained much, you can go ahead, correct, with an open
Yes.
surgery. But if I tell you that you have not done or not seen, can you do HOLEP or THULEP? Can you do it? No.
No.
But once you
No.
start practice and if you are given that this patient you have to operate, you don't mind doing open surgery.
Yes.
Okay.
So while answering these questions, you have to keep in mind small stone, small prostate, large stone, large prostate, large stone. These are the permutation combination anybody can encounter in this practice. So both are small, QRP with cystolithotripsy. If both are large, laser oblique open prostatectomy. Large means 130, 140, 150. Again 200 अगर वैसा है तो लेजर भी वहाँ काम नहीं करेगा. कितना घंटे करते बैठेंगे. ठीक है. Stone, large stone, small prostate, cystolithotripsy, PCCL plus TURP. So these are the things you have to keep in mind while answering the type of treatment, surgical treatment you are telling to the examiner. Okay, so here's prostatectomy. Can anybody tell the steps? If possible, 2-3 steps, important steps. Don't tell me painting, draping, incision, bladder opening, वैसा कुछ नहीं बता. You have opened the bladder, you have entered inside, and how will you proceed in this case?
So once
Cystoscopy is obviously done and there is no any malignancy. And diverticulum is just behind the prostate, enlarged prostate with the wide opening of the bladder, diverticular neck, and there is approximately 2 centimeter stone inside the diverticulum. This is the finding of scopy.
After opening the extraperitoneal space, we just give a vertical incision on the bladder. Just take 2 sutures on the both the sides of the incision on the bladder, and so that the incision doesn't get extended once we approach for the prostatectomy. The main 3 steps after entering into the bladder are the exposure of the prostate. We give an incision. We first in this case, because the prostatic lobe is very much enlarged in the whole of the median lobe is into the bladder, so we will just try to lift the this median lobe and identify the ureteric orifices. After identifying the ureteric orifices, I would like to give an incision just above these ureteric orifices, and then I would like to expose the prostate I will just like to do the finger dissection of the prostate. With my index finger, I will like to enucleate the prostate gland. And after taking the lateral lobes, first in this case, I will take the median lobe out. After taking the median lobe out, I will have an space to take both the lateral lobes out. And then will come my hemostasis, this
And
hemostatic.
how easy is to take the median lobe out in this patient with open surgery?
Very
Only
difficult
selectively
actually.
median lobe.
Very difficult actually because it is wholly and solely in the bladder only. So I don't have
So
any
what
seen such
thing?
a case.
Yeah. After opening the bladder, it's like everything. The bladder is totally filled with that median lobe.
Yes,
Ideally
sir.
described prayers oblique modified prayers prostatectomy is you have usually people will do modified prayers. You have to take a incision with the cautery around the bladder neck.
Bladder neck. Yes, sir.
Okay. Then
Yes, sir.
you have to dissect in between the true and false capsule. That is adenomatous tissue
Yes.
is dissected. Before that, you have to pass your finger inside the urethra and break the anterior commissure. This process is blind, except taking the incision all around the bladder neck. Rest all process is blind in the prostatectomy. So you have
Yes, sir.
to break the anterior commissure and you have to rotate your finger once on right side and once on left side in between the false and true capsule. And in the 6 o'clock, by pinching at the apex of the prostate to disconnect it from the rest of the urethra. And here, as it is blind, there are more chances of sphincteric injury
Bleeding.
in case of the Frere's prostatectomy.
Yes, sir.
Then you have to roll your finger from the behind the median lobe and come back towards the bladder neck. In same plane, because rest all of the intravascular prostatic extension is free all around except attachment at the bladder. Whole prostate is this in such by such technique it can be removed. So why you are taking the incision initially with the cautery? To avoid the distortion of the bladder neck. One. Then what will happen? There will be in such type of cases severe bleeding. So what are the options available for stopping the bleeding? First, you have to take the tape gauze and pack the fossa.
Yes.
Apply the pressure. Wait for some time, 10-15 minutes. Okay. If it is, then remove the pack and reassess. If it is bleeding, still bleeding, then see under vision any active bleeder at 4 and 8 o'clock position because that is the area of the supply at the level of bladder neck to the prostate. If it is seen, cauterize with long pencil tip cautery. If it is not seen, then again 2 ways. Just placating the fossa or malament suture, that is encircling the bladder neck or the catheter. This is 1, 2 and 3. Plaking हो गया, malament suture हो गया, plication of the fossa हो गया. Sorry. हाँ. उसके बावजूद भी अगर still if it is bleeding, then you can do scopy from below, just pinching the bladder, open bladder, and endoscopically you can cauterize the active bleeder. If it is not possible, if it is not available, just pack the fossa and bring that stamp node or the tape gauze through the bladder, through the skin up to the outside, to the anterior wall of the abdomen. And after 48 hours, you have to remove that. If you feel that bladder bleeding is controlled at the level of bladder neck, bleeding inside the prostatic fossa is just for such bleeding. You have to place the three-way Foley's catheter, inflate the balloon, and give a traction. So where balloon should be kept? Balloon should be kept inside the bladder. If you put inside the prostate, it will what it will cause? Why it should kept inside the bladder? Because the traction you have to give is at the level of bladder neck, because majority of the supply is at the level of bladder, because the entry point of the supply, blood supply, is at 4.8 o'clock. If that gets compressed, the fossa inside bleeding, that will accumulate some and hematoma will form, and that will get automatically stopped. With SPC, without SPC. Again, there are studies, a number of studies. So if you are confident enough, then three-way Foley's catheter, closure of the bladder, irrigation, and how the catheter is removed and when to remove, we will discuss later. Then if you are not confident, place the SPC. I usually place the SPC. Place the SPC and PUC both. Suppose that catheter get blocked. Suppose that accidentally the bulb get deflated. At least there is one access to the bladder. So this is all about the Frere's prostatectomy. Anybody have question?
Abhishek,
Particular
I will
related
ask
to
you
the
one
prostate
question.
procedure? Please.
Yes, sir.
Dr. Gite said that you pack the fossa. Suppose after packing the fossa also, if the bleeding has not stopped, now what you will do?
Just I told
Sir,
Abhishek. You have to repeat it.
cystoscopically we'll go in and
Sir said
stop the bleeding.
cystoscopically also, now you try. But there is so much of bleeding, you are not able to control it.
Sir, I'm not aware, sir.
What about the blood
अभी बोला
supply?
ना?
Sorry,
Just now I told na.
Inferior vesical artery.
inferior vesical artery ligate करेंगे sir.
कैसा
Prostatic
करेंगे?
main sir supply is via the prostatic artery sir. So,
तो गायनेकोलॉजिस्ट किसके लिए बुलाते हैं हमको, क्या लाइगेट करने के लिए?
वो
नहीं बुलाते.
internal iliac.
internal iliac.
Yeah, so but where?
Iliac.
Internal iliac totally you like it?
Yes, sir.
No.
At the origin? Bilateral?
No. उसको ग्लूटियल क्लॉडिकेशन हो जाएंगे. पोस्टीरियर सुपीरियर ग्लूटियल आर्टरी का एंट्री पॉइंट छोड़ के उसके डिस्टली कौन सा डिवीजन लाइगेट करना है? Vesical artery is a branch of which division? Anterior division or posterior division?
Anterior division.
Anterior.
So you want to ligate anterior or posterior?
Anterior.
Or both? And if you
Anterior.
ligate both on bilaterally, what will happen?
What happened to the male?
ये तो simple anatomy है भाई.
The gluteal these muscles will go.
What will happen? After prostate, where it goes? Someone has answered. What is below prostate?
Urethra, penis, sir.
Penis. So what
Yes,
will
sir.
happen?
Erectile dysfunction, sir.
Erectile dysfunction. That is what you see sometimes whenever you do bilateral transplants. And that is why they, on other side, they always like to, don't like to take the internal iliac for two reasons. Correct?
Right, sir.
So that is the answer, that you ligate the branch of the internal iliac. That is basically the inferior vesicle, which you may not be able to identify it, but you trace it down going towards the prostate and you can just ligate it. Because there is so much of bleeding and so much of it is not like a post-mortem. So you may not be able to see it very clearly. No? Okay.
So in this
Yes.
patient, without removal of the prostate, I am not able to reach that diverticulum. So first I have to remove the prostate, control the bleeding, and then search for the diverticulum. It is very difficult to search for diverticulum. Again, just intraoperatively searching for stone is
Yeah. Now
very
this stone
difficult
is
job.
only 15 millimeter and it is in
Yeah.
the diverticulum. It is not in the
Bladder.
bladder. So how will you identify it? Yes, Abhishek. How will you identify?
Sir,
You have removed the
cystoscopically,
prostate. You have done the prayer. Now there is a bleeding. So first you like to see the stone, or first you like to remove the prostate?
first I'd control the bleeding, sir, and then
So
identify
first,
the.
once you open the bladder, first you like to remove the stone, or you like to remove the prostate?
First, I'll remove the prostate, sir.
Why?
If
Well-
the diverticulum is just in front of you, you can just pick the stone. That is not the first.
yes.
What is the first? वो अंडा पहले कि कोमड़ी पहले है तो नहीं, वैसा कुछ नहीं, तो सामने दिख रहा है तो उस पर निकाल देना. That's all.
Yes, sir.
If it is why I have removed the stone later on, because I am not able to reach the diverticulum. My finger is not reaching to the
Okay.
diverticulum due to that intravesical big protrusion reaching to the dome.
Right, sir.
Finger वहां पहुंचने नहीं दे रहा था, तो diverticulum का stone कैसे निकालेंगे? So I don't have any option rather than to remove the prostate first and go for the diverticular stone later on.
Later.
Understood. But so
Got it,
after removing the prostate, what are the different options when you can't see?
Cystoscopically, sir, then we can try to assess, sir.
Open bladder में
Open
प्रेस करने के बाद में
Open, no, open, not in open bladder, sir.
Once you open, now you are not able to see. Is there any way to locate it?
We
Sir,
can
I'm not
pack
aware.
and then slowly we can remove the pack to localize the bleeding site.
प्रीऑपरेटिवली आपको जो डायवर्टिकुलम में रख सकते हैं या इंट्राऑपरेटिवली सियाम के अंडर स्टोन का साइड कंफर्म कर सकते हैं.
Someone has already answered. See, sometimes we have to use even a Siam, to find
Right, sir.
out, and then arbitrarily just see, oh, from open bladder only you put your forceps and see where, where the diverticulum will be, and then search in that area. That is number one. Number two will be from suprapubic also you can put a scope and then you can try to see inside. Okay.
Right, sir.
So now, Yasin, what will be your answer in this management? What are the different options you will tell?
So
It is the 120
Regarding
gram of
the-
prostate.
So the second option will be, sir, if available, then we can go with the HOLIP and
So your first
If-
option will be you say, okay, I will like to, because you have seen more often and you are more confident of open surgery, you like to
open
do
surgery.
in this case
Prayers, prostatectomy.
Prayers prostate, because there is a diverticulum and there is a stone inside, correct?
Yes, sir.
So you like to combine both the surgeries and remove the stone as well as the prostate. Second option is
Prostate.
your HOLIP or
Second option,
TULIP.
if available, then HOLIP and dealing with the.
Yeah, so you have got an
this diverticular
instrument and you have
stone.
got an expertise, then you may go ahead with the laser.
Yes.
Third,
So third option will be this robotic prayers, prostatectomy.
prayers
and
you
then dealing
said,
with the
open surgery you
diverticular.
said, TULIP, HOLIP you said. Third,
And third will be the this robotic laparoscopic or robotic
or
prayers,
before that what you are
prostatectomy.
regularly doing?
It's an open
No,
mostly.
what you are regularly doing for a prostate?
TUR channel,
TUR.
we can do in stages.
In the
Stages.
stage, just start
Stage
there.
TUR.
Channel नहीं, या फिर
If you are well
use
versed
word
with the
channel.
TURP, you may do in a 2-stage and then you remove the stone.
Stone, yes, sir.
Abhishek, this patient don't have a stone and patient don't want surgery. Any other option? To
The patient,
get rid of catheter.
just channel TUR only, sir.
No. You don't want any surgery. and patient don't have stone.
Medical
130 gram, 130 gram
treatment.
prostate. Is
Would
any
like
other
to put
option
them on
available,
the
or you just have to keep the patient on case PC or peritoneal catheter? और कुछ है possible है, कर सकते हैं कुछ एक्सप्लोर करके एक्सपेरिमेंटल अंडर ट्रायल कुछ है?
No, sir, not aware, sir.
मेडिकल फीस उससे कुछ होगा नहीं।
Ideally, what I am telling is specifically made for the large prostate with having a comorbidities, not fit for surgeries. These are the primary super selective embolization of the prostate.
Yes, sir. But okay, yes, sir. Such a large prostate, sir.
If patient don't want, the size of prostate doesn't matter. If you are blocking the supply, it will
Okay.
come down.
Okay, sir. Then prostatic artery embolization, sir.
Yeah. Then what you are expecting after doing the breast prostatectomy, you have placed the peritoneal catheter SPC after how many days you want to remove the peritoneal catheter? Theoretically, practically I will tell.
Abhishek, will you like to put a drain in this case?
Yes, sir. I would like to put a drain in
Yes,
this
sir.
case.
Okay, so then when you will remove the drain?
Train PUC SPC, bolo sequence.
Sir, at the end of sir 3 weeks we will remove the PUC, sir.
No, when you will remove the drain?
And when the drain is less than
Drain
30 to
less
50
than
ml.
To you,
20 cc. Yes, sir.
my question to you: if you have done a bladder stone and you want to remove the peritoneal catheter after 3 weeks,
No, for not for an only bladder stone, sir.
so here there is a surgery is like that only, na? Just you have to open the bladder, you have done something, and you have to close the bladder. That's all. Why want to place the catheter for 3 weeks?
True.
We will like to remove the drain first. Once the
So
drain
when
is
will you
less
remove the
than
drain?
when the drain is less than 30 to 50 ml, around 4th
On
or
the first
5th
day,
day.
suppose it is 30 cc. You'll remove it?
No, sir. On the 4th to 5th day.
So you will wait
I will
to,
like to
you
remove.
will like to wait for 96 hours, 3 to 4 days, correct? And
Yes, sir.
after that, you will decide if the drain is very less, you will remove it.
Yes, sir.
Okay, so first after on the 4th day, there is no leakage and you have removed the drain. Next, what?
Yes, sir.
When you will
Perurethral
remove the
catheter.
suprapubic?
Perurethral catheter, I will remove the first.
So when you will remove the perurethral catheter?
Around 7 to 10 days.
Okay, fine. So you will remove the perurethral catheter between 7 to 10 days. After that?
After that, I will like to clamp the SPC
Okay.
and see whether the patient can void. Give him a trial of voiding. So
If
if
he is voiding
everything is
well, then you
okay,
remove the
patient.
suprapubic.
Yes, sir.
Okay, now after removal of the suprapubic, patient is saying that I am wetting from above. Whenever I am passing urine, both the side the urine is coming. Now what you will do? Abhishek.
Put a tight dressing on the suprapubic side, sir.
Okay, you have kept it. Either it will stop in 24 hours or it is not stopping.
Then, sir, do a local exploration and close the bladder wall, sir, at the SPC site.
Just
Before
place the
that, what you
catheter
will do?
from below, na?
For urethral catheter, you keep it, na?
Just
Okay,
place
yes,
the catheter from below, it will dry up.
Yes,
Okay, sir.
Theoretically, perioral catheter to be removed after the 5th day when there is SPC. But practically, yes, the perioral catheter will remain after 10 to 14 days. That is acceptable answer in exam also. SPC will be last. Whatever the answer is telling that for same protocol we are also following. You have to clamp the SPC and ask him to pass. Usually, after such surgeries, such type of patient will end up into the early 90% incontinence. Because this gland, prostatic fossa, is near about 100 cc. Okay? The
Yes.
bladder, if it is passing urine, the stream will come in And when you stand up from lying down position, whatever the urine collected inside the prostatic vessel is just trickle down, and there is incontinence. So we have to start the pre-surgery preparation for avoiding the incontinence in such type of large procedure. Giving a perineal exercise, doing a perineal exercises prior to the surgery, and that should be followed post-operative. Usually, if there is a low low any injury to the external sphincter, then that whatever incontinence is there in initial phase is completely resolved. Just matter of time, week or 2 or 3 weeks. After complete getting the control, you have to. I usually keep SPC till I am satisfied for the result of surgery, clamp SPC, and I will remove the SPC later. Suppose that incontinence in spite of perineal exercises is not getting control in a few days or weeks, and you have to give a Faraday stimulation.
What medicines you can give?
For the incontinence only.
Yeah, for incontinence, which are the medicines?
Anticholinergics, we can start with antimuscarinic, solid and oxybutynin.
The bladder will work. Here, there is a chances of having a stress incontinence more than urge incontinence, because the amount of resistance provided by the external sphincter with injured or without injured to the bladder pressure created is less. You have removed the resistance, and in such situation, bladder will act like a vagabond child, sometimes overactive, sometimes underactive, because the chronically obstructed outlet is suddenly get removed. So duloxetine,
yes, sir.
that is another drug, can be added with perineal exercises with Faraday stimulation. If it is still incontinent, and the temporary conservative treatment is applying the penile clamp, and check periodically, continue to wait for at least 6 months and reassess by doing the SCOPy, SOS urodynamic study, and if at the end of 1 year, if it is still there, label it as a post-prostatectomy incontinence and treat with the artificial urinary sphincter. So this is the post-operative things what can happen in such type of patient. The thing is, we will just go to the chat, sir. Someone has asked 3-4 questions again. 8 questions.
Yeah, what are the questions? Duloxetine, you can give 20 milligram BD, or you can give 30 milligram BD, or some people give 40 milligram BD. Even imipramine is dexonil is also very useful in such patients.
Sir, CA prostate is rolled out. Yes. CA prostate is rolled out in this case. Question mark. Should we do MPMRI or trust guided biopsy to rule out, then proceed further? Please guide. Okay. So CA prostate, we have discussed only the PSA density, and it is 0.01. So it is less than normal. The chances of having malignancy is less. Still, if you want to do MPMRI, ideally MPMRI and PSA density both are complementary with each other, and if both have done, that is not the wrong. But here, I have not done an MPMRI, as there is no any signs and symptoms of heterogeneous palpable hard nodule or digital rectal examination, and PSA density is normal. So I have not preferred to do a MPMRI. But in exam or practically, if you do a MPMRI in this case, that is not wrong. That answers your question. Any consensus on combining QRQ with bladder stone? Yes. Small stone, I already told, it is dependent on the size of the prostate and size of the stone. Large stone and a small prostate, again, it can be combined together. I have done a number of cases by doing the TORP for small prostate and later on. If there is very large stone, then cystolithotomy can be done and just close the bladder with placing the SPC or cystolithotherapy if the stone is soft oblique PCCL. Initially, total complete stone fragment removal and TORP. And large stone, large prostate already discussed. It is open surgery versus full. So both surgeries can be combined together. Answer to your question. And to remove first stone, if bleeding occurs, then searching stone would be difficult. Agreed. If it is seen in front, diverticular is seen in front, then you can removing of the stone prior to the prostate removal is a good idea. Antegrade scopy in open bladder is not easy job because whatever the irrigant fluid you are using that get extravasated, you have to pinch the bladder and do with some backup forces and you have to do a scopy antegradally. But antegrade scopy is possible, but not easy. And sequence of bleeding control after adenoma removal for 10 to 20 minutes with pressure. Remove the pack. If bleeding is controlled, place the catheter, inflate the balloon, and the balloon is kept inside and give the flash. If it is still bleeding, then if it is not seen, like at the prostatic fossa or malamine suture, that is the other two more options. Again, one more option is just doing the scopy and do a electroporation of the bleeding vessel. Still, if it is not possible, just tag the fossa and place the catheter, place this SPC, then bring that tape was through the bladder, through the skin at the anteabdominal wall. After 48 hours, just remove the pack and reassess again. So these are the options available for controlling the bleeding. So that question is over. If you need doubt, please ask.
Sir, I had one question, sir. Sir, what about the renal stone, sir? Sir, वो जो 10 mm का renal stone है,
Yes. So what you will do for a renal stone? It is in the middle calyx.
Yes, sir.
So you tell me.
So what is the option today?
You tell me.
Sir, option.
Only two options available. The stone
Yes,
is
sir. Will
soft.
be an RI.
Three options available. The Huntsville unit is less than 1,000. SWL, RRS,
RIRS,
that's all.
PCNL.
But in
Yes, sir.
second
You
setting,
don't
not
have
in
to. You don't have to do everything at the same stage. You can say that I will stage it and do it later on.
Okay, sir.
It is non-obstructive middle calyx stone.
Yes, sir. That's
Yes.
So in this, it is the 1 centimeter stone, 930 Hounsfield unit. The first choice, if you have got available, I think RIRS will be the best. Or you can do SWL because it is in the middle calyx. And if you don't have all the facilities, then Minipug.
Agreed.
right.
Fine. Okay, so the last thing is, suppose you have done the surgery, you have removed everything. On 14th day or 15th day, patient starts bleeding.
Causes and management.
Abhishek.
Yes, sir.
What
Sir,
is
he
the
can
cause
be
of the
bleeding from
bleeding?
the. There can be sir, bleeding from the prostatic fossa, sir.
This is primary bleeding, secondary bleeding.
This will be secondary bleeding, sir.
So what is the cause of secondary bleeding?
Slippage of the ligate.
What is the cause of secondary bleeding?
Failure of methods of hemostasis, sir.
Slippage of the
Secondary
ligate.
bleeding is secondary to what?
bleeding is always due to major time infection. 2 हफ्ते के बाद में कहीं को लाइगेचर निकल जाएगा. जब
नहीं, yes,
तक
sir.
उसका वो ओपनिंग का कोई पेटेंट रहेगा वैसे को.
Secondary bleeding is most of the time secondary to
Infection.
Infection. So how will you manage this patient? Even after your TRP patient comes on 15 days, 16 days.
So we'll manage by embolization.
Embolization, directly
Three-way
embolization.
catheter. So put the three-way catheter, start irrigation, and start with the antibiotics.
Yes.
Don't tell direct embolization in exam. Doing a scopy, assist. Therefore, first catheter, three-way police catheter, irrigation. If not getting results, then scopy and anti-vision quadration of fossa. If it is still not resolved, then embolization. Tell sequentially. Practically, your answer is right. But theoretically, you have to tell every step.
So most of the time, if the bleeding is not very severe, okay, you give antibiotics, you give, even some people give tranexamic acid, right? And they
Right,
put
sir.
the catheter and they give a traction, mild traction, and everything will settle down. Suppose if there are clots, you might have to take a patient inside and you might have to remove the clots. And that time you can see from where the bleeding is coming and you can coagulate the fossa. And the last thing, what you are saying, okay? Go very systematic.
Right.
Another
Okay.
another option is if this patient doesn't have intravascular protrusion and 130-gram prostate, good surgery. One of the good surgery everybody should know and able to do it is Millian's prostatectomy. Less bleeding, direct control of vessel, under vision surgery, and chances of incontinence is very less because disconnecting the prostate prostatoco membranous junction or apex is under vision with using the cord. So Millian's prostatectomy is the best treatment option for large gland without having a large intravascular protrusion oblique without having a bladder stone. अगर ऐसा कुछ है तो bilobar large prostate Millian's is the best option.
Okay, sir.
गौरंग शाह सर बहुत अच्छा करते हैं Millian's prostatectomy एकदम बढ़िया.
Next time we can discuss the steps of Millian's, and we can request him to show some videos of his polyp, 5 minutes, 7 minutes video.
अपना
Maheshwari. Correct? Okay.
Right, sir.
Fine. Any other questions? Anything remaining?
There are no
Sir, I
questions.
have a question that Sir said that during hemostasis, if it is not controlled by packing, if it is not controlled by taking the suture, then we will do this cystoscopy and control it, transurethral. But sir, how can we control, sir? I couldn't, sir, actually get it. How can we control with the cystoscopy?
You have opened the bladder. If you remove the
bladder is open.
then one person to just pinch the bladder or close the bladder with cup, and another person from down, you have to do the scopy. Use the irrigation with some pressure. Then if the bladder is visible, under vision you have to cauterize. This is one way of controlling the bleeding. If the bleeding is very gross, seeing the bladder, the bladder, or I am agreeing with your concern of open bladder and doing a scopy is not easy.
Next time, sir, I said we are going to.
Can we use dutasteride? Dutasteride will not act immediately. So for the acute bleeding, when there is acute
के
bleeding,
बाद उसका इफेक्ट होगा जब तक वो पेशेंट ब्लीडिंग होकर चला जाए.
see, dutasteride people are using it to decrease the bleeding during prostatic surgery.
Pre-operatively using finasteride or dutasteride or combination treatment to have a decreased or reduced bleeding intraoperatively in URP. Few centers are using it, including KM, they are using the combination treatment preoperatively in large glands before doing the TUR, and they are saying that there are less bleeding while doing the TUR.
Yeah.
Next time, Sarah said we are going to talk about millions and video and all. So please read the procedures.
Yes,
Yeah.
sir.
आप लेजर आप बता दो सर, वीडियो आपका पास होगा तो होगा ही ना।
Yes,
और
sir,
सर
but-
मिलियंस के बारे में बताएंगे। एक शॉर्ट 10 मिनट का एक्सटेंशन ऑफ टुडेज प्रोग्राम कर सकते 10-15 मिनट।
When is your exam, Abhishek?
Sir, June.
Sir, June.
June. Okay. So I think another 2 or 3 clinics will finish off all our case presentation, and then we will decide how to go about. Okay. So please prepare all your suggestions, because you people will be busy in studying, and whatever subjects you want, please let us know. So we will also prepare, and accordingly we'll call the presenters also, so that you have a practical as well as a theoretical knowledge.
Anything, it is not necessary to know everything for us also. तो अगर नहीं आ रहा है तो पढ़ के बताएंगे, ऐसा कोई प्रॉब्लम नहीं। आपको कुछ गलत भी हुआ है तो आप हमको बता सकते हैं कि सर ये चीज तुमने रॉन्ग बता दिया था, ऐसा ऐसा उसका ये है, क्या बोलते उसका रेफरेंस है और उसमें ये चीज गलत है, तो आई डोंट फील बैड अबाउट दैट, बिकॉज इट इज जस्ट दिस whole class, the purpose of this class is to make me myself as a upgrade and give whatever possible from our side to all the students listening.
Same for all of us.
Yeah. तो उसमें कोई हमको ये नहीं है कि भाई कुछ गलत भी होगा तो उसमें गलती एक्सेप्ट करने में कोई दो राय नहीं।
We have read some time back, things could have changed, so you can tell us.
Yes, agreed.
Yeah.
And I request whoever is answering, please go into the literature, find out the papers or whatever studies are on that, and at the end, please tell us which are the studies you have come across in the journals. So please remember next time. Okay.
Incidence of
Right, sir.
bladder stone with BP is 10%. Last.
Right, sir.
Okay. Thank
Okay,
you very
good
much.
night.
Good night. Good night.
Good night,
Thank you,
Gaurang
sir.
Shah, sir.
Good night,
Bye.
Gite.
Good night,
Good night, Hiren
Abhishek.
Sodha, sir.
Good night,
Good night,
everyone.
sir.